Hello everyone and welcome to the next topic on oral infectious diseases. In this topic, we will be stressing more on HIV, the oral manifestations of HIV, and Candidiasis in particular. So the learning outcomes for the DTS curriculum are as follows. By the end of the topic, the student should be able to classify oral infectious diseases, namely bacterial, viral, and fungal, explain the various types, etiopathogenesis, clinical features, histopathological features, treatments of candidiasis in detail, understand the etiopathogenesis, clinical features, histopathology and treatment of HIV infection, and explain the oral manifestation of HIV in detail. Okay, when you need to categorize infections of the oral mucosa, we basically categorize them into viral, bacterial, and fungal. So under viral, we have, let me put on my pointer, we have herpetic stomatitis, chickenpox and herpes zoster, herpangina, hand, foot, and mouth disease, measles, and infectious mononucleosis. Under the bacterial, we have tuberculosis, actinomycosis, syphilis, noma, and gonorrhea. So the ones that are highlighted here in green are the ones that we will be stressing on. Some of them would be covered as part of the lecture, and some of these infectious diseases would be covered as part of case-based learning. The common ones are candidiasis, which will be dealt in detail, and mucormycosis. Now, mucormycosis, I think, should strike well in your mind when you hear the term. This was the disease, fungal infection, which was found to have been reported commonly in post-COVID patients reporting for dental treatment, specifically in India. The reason for that has not yet been identified. The cause for that has not yet been identified. Anyways, we will explain that as we go further. All right, the last one would be oral manifestations of HIV infection. So starting off with herpetic stomatitis. Now here you have two pictures here. Both of them show erythematous lesions seen on the gingiva, on marginal gingiva of young children. All right. So this is a common presentation in young children, and this is caused secondary to herpes infection. All right. So let's look. Now, herpetic stomatitis is caused due to HSV1 and HSV2, which stands for herpes simplex virus 1 and herpes simplex virus 2. Young children, it's usually transmitted by droplet infection. The incubation period is of 5 days. That means that is the time from the point of exposure to the point of clinical symptoms developing. And patients complain of prodromal symptoms. Now, prodromal symptoms is a term that is collectively used to describe flu-like symptoms. Right, so the patient has fever, body ache, malaise, so on and so forth. Right, numerous vesicles erupt on the mucosa and the lips with widespread inflammation of the gingiva, as I showed you on the previous slide. The lesions, however, resolve in 10 to 14 days. So in these patients, basically they need to be given symptomatic and supportive treatment, and the disease is self-restricting, and the patient would be able to recover. Okay. Right. So now this is the histopathological image of the erythematous area in herpes stomatitis. Now, mostly herpes stomatitis is treated symptomatically, as I just mentioned on the previous slide. This image is just for academic interest. That means for you to understand what exactly takes place microscopically in these viral infections. So, first of all, viral infections always mostly affect the tissues of epithelial origin, right? And when they affect the epithelial tissues, right, what they cause is basically intraepithelial vesicle formation, all right, and what is noted is ballooning degeneration of the epithelial cells. So technically, this space that you're seeing, this is the epithelium. This entire stretch is the epithelium, but the cells that constitute normally the the stratified squamous epithelium, the layers of the epithelium are destroyed here because of ballooning degeneration. All right. So what do you mean by ballooning degeneration? Basically, the epithelial cells undergo increase in size, all right, which makes them look like a balloon, and that is because of the effect of the viruses on the epithelial cells. Okay, so basically intraepithelial vesicle formation takes place. Now this is purely for academic interest. Herpes somatitis patients do not need to undergo any biopsy for diagnosis. So the diagnosis is based on clinical symptoms and treatment is supportive. Right, so the pathology of herpes simplex infection is an infection of the epithelial cells. Viral replication results in cytopathic changes in the epithelial cells, which causes the vesicle formation. Now, many viruses actually have a characteristic of latency. That means they remain dormant, and they remain dormant most of the times in nerves and nerve ganglions. Now, herpes simplex virus infection, the virus remains latent in the trigeminal ganglion. So, what does this basically mean? It basically means that following this childhood infection exposure to HSV that takes place, the virus remains latent in the ganglion, and whenever there is an episode where the immunity of the patient is low, there is always a chance of a secondary HSV infection developing, right? Secondary HSV infection developing, which is what is commonly seen in grown-up adults during stressful period, during the menstrual cycle, so on and so forth, wherein you develop herpes labialis. So the activation of the latent virus which is residing in the trigeminal ganglion during the adult life, during the course of the adult life, is basically related to the secondary herpetic lesions that develop at the later point in time. Right, exactly something that I just explained to you. These are herpetic recurrent herpes labialis. Okay, vesicular stage here. All right, so small vesicles that erupt on the upper lip and then eventually they undergo crusting. Now these are secondary lesions, right? So because of the latency of the virus, which gets reactivated during various phases of the patient's adult life, during which there is an immune suppression of the immunity for any reason. It could be a flu, it could be, as I told, a hormonal imbalance, or any other reason for. Right, now this is herpetic whitlow. All right, so basically, if you this is a lesion that's commonly associated with oral healthcare providers or healthcare providers who happen to who do not use gloves or personal protection equipment. All right, specifically gloves here, and their skin comes in contact with the saliva of the patient who has herpes, and what happens is the virus gets inoculated onto the skin of the finger, and then it gives rise to a vesicular eruption over there, and then eventually giving rise to multiple crustacean around that. So this is typically seen in dental surgeons, dental surgery assistants, dental therapists, and others who do not actually follow infection control protocols and get exposed and have got exposed to patients with herpes. This can also happen in patients with autoinoculation. That means the patient who has active herpes infections in the oral cavity, they constantly use their finger to touch or manipulate the lesion, and there would be a fresh lesion that would erupt on the finger, right? So that's basically herpetic whitlow. These are the slides that we've just gone through are important here, and you need to be familiar with these terminologies, with the concept of how herpetic whitlow develops, the concept of what is secondary herpes, what is herpes labialis, what is primary herpetogingival stomatitis. Moving on, the next viral lesion is herpes zoster. Now, chicken pox and herpes zoster are caused by the same virus, which is varicella zoster virus. Okay, VZV. Spontaneous reactivation of virus is seen when host defenses are depressed. All right. So again, the core concept is again the same. So chickenpox is, is a common childhood disease, but in the late but of late recently, there is a vaccine available for chickenpox, and many young patients these days have not had these childhood diseases, and but have got immunity through vaccination. All right. Now, patients who have got chickenpox, basically the disease is self-limiting, has a course of 7 to 14 days, and then you develop permanent immunity uh, once you actually develop this infection. However, because of the nature and the characteristic of the virus remains latent in the nerves, all right, and in adult life, there could be unilateral lesions that are seen along the course of the nerve. So lesions are preceded by prodromal symptoms, which I've already told you. That means a flu-like presentation, body ache, watery eyes, running nose, so on and so forth, right? And so a reactivation of the chickenpox virus or the varicella zoster virus in adult life is what is described as herpes zoster. And because it remains latent in the nerves, the lesions always are unilateral and always are seen along the course of nerve. So depending on the nerve that is affected, we would see lesions around that. Right. So in this picture, you can clearly appreciate the lesions of herpes zoster here. All right. This is an elderly white gentleman. This is a picture from the internet that I have taken here. So you can see, you can clearly appreciate the unilateral presentation, clear midline that differentiates normal from the lesional area. So the tongue is involved, the face, the skin on the face is involved in the lower side, lower half of the face, right? So this is basically involving the nerves, the facial nerve as well as the lingual nerve. Okay, so in this picture again, this is intraoral lesions of the herpes zoster, right? So this is the eruptions that are seen on the palate. Okay, clearly on unilateral, all right, on one side of the palate, and the pinpoint vesicles that you're able to see. Okay. So this disease resolves in 14 days, as I mentioned to you, and the complication, the post infection complications include two. One is post herpetic neuralgia, that is nerve pain associated with this following recovery, and next is Ramsay-Hunt syndrome. So Ramsay-Hunt syndrome basically is also called herpes zoster oticus, where there is following the herpes zoster infection, there is basically facial paralysis and hearing loss, okay, associated. So this is the complications of herpes zoster. Moving to oral manifestations of HIV. Okay, so this is the diagrammatic representation of the HIV virus, which is a retrovirus, right? So, okay, let me just put on the pointer again. Right, so on the outside you have the envelope glycoproteins, right? These are the envelope glycoproteins. These are the core proteins, that is P17, P24, and P7, which is these, right? This and this one, right? While the third set of uh, of structure in the HIV virus is the reverse transcriptase, right, which is present in the core, right? So this is P66, P66 and 51, P32 and P11. Now this is just a color enhanced diagrammatic representation of the same. You're seeing the envelope surface glycoprotein, right, GP120. You're seeing the envelope transmembrane glycoprotein, GP41, right, which is the stock, and then you have the the membrane here, the membrane associated matrix protein, right, B17, and then the core capsid, right, which is B24, okay, which is B24, and then the two RNA molecules that we have, all right, and the reverse transcriptase, which is composed of the protease, polymerase RT, RNase, and integrase, right? So this is the antigenic structure of the RNA virus, which you are already familiar from your second year as part of microbiology training, right? Okay, so to just refresh you through the pathogenesis of HIV infection, HIV infection majorly targets two systems, that's the immune system and the CNS, right? The virus has very high affinity towards receptors of the CD4 cells, right? The two cell surface chemokine receptor molecules, which are CCR5 and CXCR4, serve as co-receptors for the cell, all right, for entry. And individuals with homozygous, something very interesting here, individuals with homozygous mutations of CCR5 are found to be completely resistant to HIV. So basically, I believe you're already familiar with it, but if you're not, I'd like to tell you that for any viral infection to actually occur in a human being, we need receptors to actually identify, first of all, antigen presenting cells, which will be able to identify the virus as an antigen, then present it to the immune cells. And on the immune cells, there have to be receptors that bind to it and then allow the entry of the viral particle, the viral DNA or RNA into the cell where it replicates. So basically, when we talk about these unique individuals who are resistant to HIV, these individuals basically lack this receptor over here, which we were talking about, CCR5. All right, so basically there is a mutation which basically leads to the absence of the receptor, and because the absence of the receptor, the HIV virus does not get detected, and thus the virus cannot affect the individual. All right, and so this is a very minor component of the population, but this is an interesting fact that I wanted you to know. Right, so this is a diagrammatic representation of the same, right? So the virus goes in, it has an affinity to the CD4 cells, right? So there is binding that takes place, then the viral components go in, the viral RNA reaches out, it binds with the DNA of the CD4 cell. There is replication using the reverse transcriptase enzymes present in the HIV virus. There is replication of viral RNA that takes place, and as these viral proteins are formed, they actually cause budding, and their number increases. And as these viral particles are formed and budding takes place, the CD4 cells get destroyed, thus bringing down the CD4 cell count, so which is something very important and crucial in terms of HIV and its progression to AIDS, right? HIV stands for human immunodeficiency virus, right? Once this is just the explanation of the same, once internalized, the viral genome undergoes reverse transcriptase and forms complementary DNA. The complementary DNA becomes integrated into the host genome. The provirus may stay latent or transcribed to form complete viral particles which bud off from the cell. Such productive infections associated with excessive viral burden lead to the cell death. So the cell death that we are talking about here is the CD4 cell death. So marked reduction in CD4 counts is the hallmark of AIDS. All right. So a patient can be HIV positive, but he or she is called is at the stage of acquired immunodeficiency syndrome or AIDS when and only when the CD4 count is less than 200. Right. So productive infection occurs only when the infected T cells is activated by exposure to antigens or cytokines. HIV colonizes the lymphoid organs, that is the spleen, lymph nodes, tonsils, and infects the T cells, macrophages, and dendritic cells, which act as reservoirs of infected cells. Okay, so that is basically a revision of your concept in HIV. So the important thing that you are going to be learning in year 3 is basically that oral there are something called as oral manifestations of HIV and AIDS that are actually seen. So that if these lesions are present in a patient who comes up to your dental surgery, then we need to suspect HIV. All right. Now, in this, there is a category. These lesions are basically grouped as Group 1, Group 2, and Group 3. So, Group 1 stands for lesions that are strongly associated with HIV infection. All right. So, what do you mean by this group? Basically, it means that if any of these lesions are present in a patient who reports to dental office, then we must rule out HIV in these patients. All right, if there are no other local causes that can be identified for these conditions. So if these conditions are seen, then there's a very high chance that the patient may be HIV positive. All right, so what comes under the group 1 are candidiasis, mainly the types erythematous and pseudomembranous. The second is hairy leukoplakia, okay, oral hairy leukoplakia, which is an infection which is caused by Epstein-Barr virus. Kaposi sarcoma, okay, which is a malignant connective tissue neoplasm, all right, again caused by a human herpes virus, okay, and non-Hodgkin's lymphoma, which is again caused by Epstein-Barr virus. Many times, patient could present with these lesions in the orofacial region. And the last is periodontal disease, under which you have linear gingival erythema, necrotizing ulcerative gingivitis, and necrotizing ulcerative periodontitis. So these five lesions are very strongly associated with HIV infection. Group 2 lesions, on the other side, are lesions that are less commonly associated with HIV infection. All right, and there's a very long list: bacterial infections, melanotic hyperpigmentation, necrotizing stomatitis, salivary gland disease, thrombocytic purpura, ulceration of no not otherwise specified viral infections like herpes simplex, human papillomavirus, varicella zoster virus, so on and so forth. And group 3 lesions are basically lesions seen in HIV very rarely or less frequently. All right, that includes bacterial infections caused by actinomyces israeli, E. coli, klebsiella pneumonia, cat scratch disease, drug reactions, right, epithelioid angiomatosis, fungal infections other than candidiasis, right, cryptococcosis, geotrichum, histoplasma, mucormycosis, aspergillosis caused by Aspergillus flavus, and other neurological disturbances such as facial palsy, trigeminal neuralgia, after stomatitis, viral infections. So this is the group 3 lesions. Now in this lecture we're going to try and focus only on the group 1 lesions. That means the lesions that are very strongly associated with the presence of which is strongly associated with the presence of HIV. So oral manifestation of HIV, group 1 lesions is what we are going to stress on. Okay, so number 1 is candidiasis. Now, it's the most common infection in HIV positive patients. Often, it is the first sign or symptom of an HIV infection. Okay, it may cause discomfort or pain, halitosis, and altered taste. Altered taste is medically referred as dysgeusia. Okay, in a known HIV patient, esophageal candidiasis is an AIDS-defining disease. All right. Now, I need you to understand that from the time a patient turns HIV positive to a time the patient actually turns or develops AIDS, it could be anywhere between many decades, right? Because of the advancement in therapy, advancement today in terms of management and care, right? So we as dental healthcare professionals basically have the opportunity to have patients, all right, who may present to us as undiagnosed HIV patients or diagnosed, all right, and on and on something called as HART, which is highly active antiretroviral therapy. So as dental surgeons, it is important for us to understand that HIV as a disease is a spectrum, right? So from the time the patient turns seropositive to the time the person is at end stage AIDS disease, there is a lot that can take place. And as a dental surgeon, our role is going to be in first of all identifying cases that are undiagnosed as HIV, with the fact that we do establish and identify the strongly associated lesions like Candidiasis, oral hairy leukoplakia, non-Hodgkin's lymphoma, Kaposi sarcoma, and the periodontal diseases that we had mentioned. Okay, so that we can bring in early intervention. And where there is an already diagnosed patient who is on therapy and needs dental care, obviously we are qualified and trained to manage these patients in our dental office. So now there are four types of clinical types of candidiasis. All right, pseudomembranous, also called thrush. Okay, it appears as a white surface change and can be frequently scraped off the mucosa. All right, so this lesion will again be covered as part of red and white lesions. All right, so pseudomembranous, it's called pseudomembranous because it's like a false membrane on the mucosa which looks like a whitish patch, and when you use a piece of gauze to actually scrape it off, it gets scraped off and leaves a raw area. Okay, the second type is the hypoplastic type or a chronic type, a candidial white form that cannot be removed and may be mistaken for leukoplakia. Now leukoplakia we will discuss when we reach there. Leukoplakia basically is defined as any white patch that cannot be characterized as any other definable disease. So that is basically leukoplakia, usually associated with tobacco. Now here we are trying to use the term leukoplakia because we have a white patch in the mouth which is because of candida, and it is a patch that cannot be scraped off. All right, so the difference between pseudomembranous and a hypoplastic form is that pseudomembranous can be scraped off, but hypoplastic cannot be scraped off. The third type of candidiasis is erythematous or atrophic. All right. Now, this lesion is irregular, often ill-defined, and it has erythematous patches. Now, erythema basically means reddish patches. All right. So they are reddish and atrophic. That means there is denuded epithelium over there. The fourth is angulocheilitis. All right, fissured lesions that are present at the commissure, labial commissures. Okay, now this is commonly seen in denture varus. All right, and is less associated with HIV. Now, what are the two types that are more commonly associated with HIV? As we have already seen under the group 1 lesions, they are the pseudomembranous type and the erythematous type. So that's what we've got to be watchful for. Okay, so now this is a picture of a patient, 34-year-old, who turned out to be an AIDS patient, and he has these white patches on the posterior tonsillar area. All right, and these are scrapable, and when they were identified on the microscope, turns out to be candidiasis. So this is pseudomembranous candidiasis for you. Now this is another image of another patient here. So this is a case of hypoplastic candidiasis that could not be scraped off the mucosal surface. All right, cultures were candida positive, and the lesion disappeared in response to fluconazole to 200 milligrams daily. So the differential diagnosis had included leukoplakia with possible dysplasia and cancer. Right, a biopsy was planned if the lesion did not respond to antifungal. So this is a rare case, right? So this is a white patch here, could not be scraped off. So when it cannot be scraped off, you think about various things. Under that, one of the list, as I told you, is hypoplastic candidiasis. So candidiasis being fungal will resolve when antifungal is given, and fluconazole is an antifungal. Okay. The thing with antifungals is that they are very few antifungals as compared to antibiotics that we have, and whenever a patient with fungal infection requires antifungal therapy, the therapy needs to be followed, the regimen, and the regimen needs to be completed, because if you do not complete the regimen properly, then there is always a chance of a more resistant fungal infection developing, and we have a less choice in terms of the battery of antifungals that are available. Right, now this is a clinical picture to show you an erythematous form of candidiasis with minimal white appearing surface colonies that was associated with an AIDS patient here. Basically, palatal pain prompted the patient to come to the dental office, and on seeing the erythematous palatal lesion, you can do a swab here, and once the swab is identified and it's identified as candidiasis, we go ahead and treat the patient. This is again a picture of angular cheilitis. Now this is angular cheilitis, basically the whitish lesions that you notice at the labial commissures. This is an image that is taken from a 60-year-old homosexual man who, in whose case this happened to be the first indicator of an HIV positive status of the patient. But in general, most commonly, when we look at oral manifestations of HIV, under candidiasis, the most common type is pseudomembranous type and the erythematous type. Now, diagnosis of candidiasis lesions are clinically characteristic, right? Smears enable visualization of spores and hyphae or mycelia. There are cultures of lesions that can be processed on dextrose plates. You know that very well. The medium that is used is Sabrod's dextrose, right? Sometimes, if required, biopsy is performed, all right? The presence of hyphae or spores can be confirmed utilizing special stain called PAS stain or periodic acid shift stain. Okay. Treatment for candidal infections basically is topical or systemic antifungal agents, which include nystatin, clotrimazole, troches, or oral ketoconazole or fluconazole. Right. So the regimen is will be elaborated to you in detail. This is the microscopic image of a swab that is done, right? So what you're basically seeing are these are epithelial cells, right? And these are the hyphae and spores that you can see, right? The what's written down here is gingival mucosal candidiasis in a 30-year-old HIV patient who also had precocious periodontal disease. The lesion resembled somewhat those of hypersensitivity reaction, right? A gingival-labial smear of the patient in A revealed hyphae, mycelia, spores, and antifungal. Okay, and the background of squamous cells can be seen. So lesion cleared up with antifungal therapy. So this is the image of a culture plate. This is the dextrose agar medium, right, on which the swab has been inoculated, and this is the culture that took place. So basically, one of these colonies can be made into a smear and stained, and then we would be able to identify the spores and the hyphae. This is mucosal biopsy, right? What you can, these vertical magenta color projections that you see are basically the hyphae, okay, and the round things are the spores. Okay, so the next condition which is common in HIV is oral hairy leukoplakia. As I told you, it is caused by Epstein-Barr virus. So basically, you see corrugated hair-like white lesions that are found unilaterally or bilaterally on the lateral surface of the tongue. It is not related to cancer, precancer, or dysplasia. Okay, and the characteristic features include epithelial hyperplasia, immature keratin, and surface changes in the epithelium secondary to viral infection. So vacuolated squamous cells or balloon degeneration or coilocyte formation is common in any epithelial cell that is infected by virus. So this is a clinical picture here. You can clearly see the corrugated white lesion on the lateral surface of the tongue. Usually it is bilateral, and microscopically, if a biopsy is done, basically we will see hyperplasia. This is the area that you're seeing the balloon, the coilocyte formation, all right. And this is electron microscopic view showing the nucleus of vacuolated cells, showing the viral particles. Right, these are the viral particles basically. Now, oral hairy leukoplakia may be seen in other forms of immunosuppression as well, but rarely in healthy individuals. Approximately two-thirds of cases, all right, have candidal hyphae super infection, right? There is demonstration of intracellular Epstein-Barr virus by in situ hybridization or PCR. This which can be done to get the definitive diagnosis. Treatment here for patients who have oral leukoplakia is antivirals in high dosage, okay, mainly acyclovir or topical application of keratinolytic podophyllin. Okay. Now this is a picture of DNA in situ hybridization where the Epstein-Barr viral DNA incorporated into the surface epithelium is identified by the brown color staining that has been noticed. Now, under the group 1 lesions, you also have HIV associated malignancy, which is Kaposi sarcoma. As I told you, is the most common malignancy associated with HIV infection. Multifocal neoplasm of vascular endothelial origin. So, Kaposi sarcoma is of vascular endothelial origin. As I said, it is HHV in origin, human herpes virus type 8, which is responsible for the development of this malignancy. It is noted in this tumor and is thought to be involved in the development. So this tumor can arise in the trunk, arms, head, neck, which are most common. Oral cavity, hard palate, gingiva, and tongue are frequent sites where they arise. Lesions begin as brown or reddish purple zones of discoloration that do not blanch with pressure. So blanching basically is tested by using a flat instrument to press over it, and when you press over it, if there is a color change, that means the reddish or purple color becomes pale pink or pale white, that means there is blanching. And if there is no blanching, then that is indicative that probably it is related to Kaposi sarcoma. Blanching is commonly seen in hemangiomas. In later stages, all right, the involved areas develop into plaques. Or this is an early stage lesion on the palate, so it looks like brown, purple erythematous lesions, right? Lesions here like this one, you're able to see a large tumor on the gingiva, okay, which is purplish in color. Also you can clearly see the pseudomembranous candidiasis lesions that are present. So basically two group 1 lesions are present in this patient. Definitely this is an HIV positive patient. So with enlargement and oral lesions may be associated with pain, dysphagia, bleeding, difficulty in mastication, and aesthetic concerns. Biopsy is required for definitive diagnosis. So for Kaposi sarcoma, the biopsy would be required. Histopathologically, there are 3 stages, right? This is just information good to know, right? Because Kaposi sarcoma is a malignant neoplasm, right? It's a rare neoplasm, and is not something that is required for a third year student to know it in detail, but it's good to know information in histopathology. So patch stage, it has a patch stage which is characterized by proliferation of miniature vessels. Lesional endothelial cells have bland appearance and may be associated with scattered lymph. Then you have a plaque stage, all right, and a nodular stage. And however, numerous extravasated erythrocytes are present, and slit-like vascular spaces may be also present, right? The details you can refer the note. This is the biopsy of an oral lesion. This is the epithelium. This is the connective tissue, right? These empty spaces are basically proliferation of the endothelial cells. This is basically where the malignancy can easily be identified. This is what has been enlarged here. You can see the atypical cells here, the spindle-shaped cells, atypical cells, and all of these orange cells are basically extroverted RBCs, something that is seen in the histopathology of Kaposi sarcoma. Moving on, non-Hodgkin's lymphoma, which is also a group 1 lesion, is the second most common malignancy in HIV infected individuals. Most common are non-Hodgkin's lymphoma, rarely T cell or Hodgkin's type are seen. Tumors arise from a combination of Epstein-Barr virus, antigenic stimulation, and immune dysfunction. So more common in the extranodal location, commonly in the intraorally, they may present as soft tissue enlargement of the palate, retromolar region, tonsillar pillar, and hypopharynx or the tongue. So these are common sites. If there is a swelling, that is present in these sites, okay, and the patient comes to our dental office for a checkup, and we notice these things, then we are required to investigate. So histopathologically, frequently they resemble Burkitt's lymphoma and are of intermediate type more frequently than a high-grade malignancy. The prognosis of these lesions, basically aggressive lesions, these are aggressive lesions with poor prognosis. Okay, so non-Hodgkin's. So here in this case, this is a patient who turns up to the dental office. He has this swelling in the retromolar region. On doing the biopsy, it turns out to be a non-Hodgkin's lymphoma. On further investigating, the patient turns out to be an HIV positive patient. Alright, so the last group 1 lesion is the gingival and periodontal lesions, under which you have linear gingival erythema. Affected patients demonstrate a distinctive linear band of erythema that occurs along the gingival margin and extends 2 to 3 meters apically. Let me tell you, it's not very easy to identify it clinically. Even many experienced clinicians would find this difficult to identify. It's not associated with plaque formation. So basically, if there is gingival inflammation where the local factors are not present, then it should raise alarm bells and we need to investigate. Typically, they are non-responsive to conventional oral hygiene measures. That means in these patients, when you see the inflammation and you go ahead and do oral prophylaxis, there is no resolution of the inflammation. So it's an unusual form of candidiasis that has been identified. So if you look at this patient here, there is gingivitis, which was the mark here. So basically this mild erythema that you are seeing on the marginal gingiva all along the maxillary teeth, right, as well as even here is basically the linear gingival erythema. What is to be noted is there is severe gingival clefting involving one tooth, right. The inflammatory change in the maxillary gingivas is what is referred to as linear marginal erythema. Necrotizing ulcerative gingivitis, relatively frequent occurrence. Okay, interdental papillas are blunted, highly inflamed and edematous with punched out areas of crater-like necrosis covered by gray pseudomembrane. Now, this presentation is very pathognomic of necrotizing ulcerative gingivitis. Fetid odor, extreme pain, and spontaneous hemorrhage. Another very characteristic presentation. So associated with lymphadenopathy, fever, and malaria. So here in this particular patient, if you look at it carefully, the interdental gingiva is undergone necrotic change. There is pus all around, as you can see, right, and there is inflammation of the gingiva. So this is very early stage. Advanced stages, so this patient would be accompanied with fetid odor and all the other features that we just mentioned. Advanced stages would go on to see necrosis of the large areas of soft tissue of the periodontal and loss of the tooth. Now, HIV associated periodontitis is the advanced stage of this. So there's rapid loss of alveolar bone support, gingival hemorrhage, soft tissue necrosis, and severe deep pain. Up to 90% of periodontal bone support is lost. Bone loss pattern is irregular and associated with minimal pocketing. Right. So advanced periodontal lesions may be complicated by massively destructing necrotizing lesions of adjacent bone and soft tissue, and this is what is called necrotizing ulcerative periodontitis. So look at this patient here. He has a large periodontal defect here, right? Exposure of the root surface, destruction of the alveolar bone. But look at the inflammation. There is very minimal inflammation that can be seen. The reason why this inflammation is very minimal is because the patient is HIV and there is suppression of the immune system. So when there is suppression of the immune system, there is a very easy chance of the infection to spread rapidly, which is the cause of concern. So as dental surgeons, it is important for us to be able to identify or rather the alarm bell should ring when we see gingival inflammation in patients who do not have local factors. That means plaque and calculus. And these early inflammatory lesions of the gingiva and periodontium do not resolve to conventional treatment. So that should raise an alarm bell for us. This is another image here where it's lead to a bone defect here and necrosis of the periodontal tissue. So this is necrotizing ulcerative periodontitis. Okay, so this brings us to the end of this topic on oral infections and HIV. I hope you have understood the core concept. To supplement this, we will discuss in detail the case-based learning scenarios for the bacterial infections as well as for candidiasis during the practical sessions using Google Classroom. If you have any query, please reach out to me and then we can have a discussion. Thank you very much. This ribbon is the red ribbon that is worn on World AIDS Day, which is the 1st of December, and the fight against AIDS currently still continues. Currently, we do not have a vaccine for this infection, but because of the advanced therapy that is available, the newer drugs that are available, a person who is diagnosed with HIV can go on to live a normal life expectancy if he or she uh, takes care of their health and continues with the highly active antiretroviral therapy. Thank you very much.